Well, I think I will begin at least with the introductory remarks. Those of you who have been on these have heard this a number of times already, but you'll have to hear it one more time. I'm Sue Etkind. I'm from Eastman Cares, and we have an educational subcommittee who runs Lunch and Learns. We've been doing it for a few years. This year, of course, is different this year and last year. But we have been running a COVID-19 seminar series. It began in November, and we have 3 more lectures, counting this one. And then it will be over, and hopefully, as Nancy said, things will be calming down and we can think of other things to have for educational presentations. But the committee has been very resourceful trying to put these together, and I really appreciate all the hard work that's gone into it. A couple notes for Eastman Cares. One is that we do have the local community resource guide available. It is very helpful in terms of local resources, particularly for aging in place and issues relating to that. It is available at South Cove as you go into the entry. It's also online on the website, so please take a look at that if you need it, or give it to someone if you think there is someone who could benefit from it. The other thing that we have this year is the eCares Connection, and basically that's an opportunity for anyone. I mean, if you know anyone yourself, or if you yourself think maybe you have a need to just have a conversation with someone, you know, whether it's once a week, or a daily, monthly, whatever. We actually have volunteers who are very willing to check in with anyone who thinks that they would benefit from that. So that resource is available. It's Eastman Cares at eastmannh.org. And you can just send us an email and we'll figure out what we can do to help. So we have those 2 things to mention. About this, the webinars themselves. These webinars were set up so that there would be no video for the participants, that we would just have our speaker. And we also have Paul Etkind here, who's going to manage questions. So because there's no video, there's also no audio. However, that being said, we do encourage everybody to ask questions, and you can do that through the Q&A. And we really would rather have you do it through the Q&A than through chat, so Paul only has to monitor like one thing at a time. But so we would ask that if you have a question, put it in the Q&A. Paul will monitor that, and Dr. Gagliano will take questions at any point throughout the talk or afterwards. So please use that resource for your questions and answers. We do appreciate evaluation and feedback, and again, if there's anything you would like to say about this or any of the lectures, or any suggestions for future lectures, we would appreciate that. That's the same email, eastmancares@eastmannh.org. So please feel free to share that with us. This is being recorded, and as you know, it is available. Lori does make these available on Eastman Highlights and on the website. Okay, before we start on this speaker, I would like to talk about our next presentation, and that will be, I also want to mention that the last 3 talks are all from our Eastman Healthcare Public Health Review team here. And that being said, I don't know how many people know, but this group has met every single solitary week at 8 a.m. Since it's been probably more than a year now, every single week, to talk about how to protect our community. And I want to give a shout out to them because they have done an incredible amount of work, and I think we're all very appreciative. So the last 3 talks are all members of our public health team, and Dr. Ken Dolkart, who many of you I'm sure know, will do the next one toward the end of April, called Our Plague Year, Who Died and Why. So that will be the next one, and then Paul Etkind will do the final one, which we will announce as we move forward. So I hope you'll join us for those, and I am thankful for those of you who joined us today. Today, our speaker is Dr. Nancy Gagliano, again, one of our own, although right now she's in Florida, and that background is actually, it may look like a background, but it's a real thing if you walk out her door. So we are very happy to have her join us. She is a Harvard Medical School and Northeastern DeMoray McKim, is that how you say that? Big graduate. She's an internist by training. She currently leads the Rapid Acceleration of Diagnostics for COVID-19 testing, large-scale deployment core, which is to support NIH's work nationally. She spent years previously at the CVS Health as Senior Vice President and Chief Medical Officer of the Minute Clinic, overseeing quality of care, point of care testing, and growth expansion for, I don't even know how many now, but 1,000+ clinics who see like 6 million patients annually. She spent 21 years at Mass General as a Harvard faculty primary care provider and ultimately Senior Vice President of Practice Improvement. So it's quite a resume. And we are very happy to welcome Dr. Gagliano to our talks. And with that note, I will turn it over to Nancy.
Thank you very much, Sue. And I'm going to hopefully share my screen. See if I can make this work. Can everybody see my screen? Paul, yeah. Can I have a
yes
shake of the head? Great. Okay. Well, great to have everybody here. I wish I could see your faces and your frowns and questioning faces, but I'm sure we will make this work. I'm thrilled to be here to share with you a little bit about a lot of work that's been going on behind the scenes over the last year. I know the media has talked a lot about testing, and for a variety of political reasons, the project that I've worked on has been a little bit under the radar screen. It's called the Rapid Acceleration of Diagnostics, otherwise known as RADx. My goal today is to share a little bit about the project, as well as talk about how to think about testing, in one's community, talk a little bit about what's confusing everybody with antigen and PCR tests, and then share with you some of the work that we have done. And as Sue highlighted, I'm happy to take questions along the way. Paul is going to moderate, and let's get going. So just about a year ago, Congress approved a mightily large budget to improve diagnostic testing. Our project was funded initially to the tune of $750 million, and ultimately the RADx project was funded over $1 billion over the last year to improve testing platforms. So early on, I'm sure you remember all those days, we don't have good tests, we don't have enough tests. And Congress approved this budget. The concept behind RADx, Rapid Acceleration of Diagnostics, was if a group of people, experts, could get together with enough money, could we rapidly produce tests and get them out to the market to meet the daily need of 6 million tests a day. That was what was projected to be needed to help contain COVID. And part of the challenge was, let's be innovative in the types of tests as well as the location of tests. So really focused on point of care tests that could be done at home, in emergency rooms, in clinics, in schools, in businesses, as well as improve the capacity in large testing sites. So that was our charge. The concept was based on a Shark Tank-like concept where if we put out an open solicitation across the country to startups, to academics, to businesses, and have them apply for funding, we could set up a process where the best and the brightest ideas would go through a series of support and thresholds to get to the best tests possible with the greatest feasibility over the course of 6+ months to hit that goal. And I'll share a little bit more about how we went about this. It just so happened that there was a group of us called POCTERN, Point of Care Testing Research Network. And because of my CVS experience where we did a lot of point of care testing, I was on the board of this group. And this group was funded by the NIBIB under the NIH to receive that $750 million to make this all work. Some of us knew each other, but most of us had only met at meetings, and we created a network of 500 experts. None of us all have met each other, and we've been working for a year now by Zoom. I was asked to lead the piece of this project, which is the large-scale deployment piece. So I'll share about that in a second. So what we did is we had a bunch of academics, the POCTERN group, and we pulled in people from all over. We have relationships now with the alphabet soup of the government. I work very closely with the FDA, DOD, CDC, and BARDA, which is in defense. And we've pulled in over 300 IVD in vitro diagnostic experts. So they are a mix of engineers, executive, people who understand human factors, manufacturing, market research, program managers, you name it, we've got it on this group. And they have all the expertise needed to develop the tests and manufacture the tests and what requirements you need to get passed by FDA, and a lot of smart people from academia to understand all the sensitivity and the specificity and the chemistry behind the tests. And we've made an incredible team. And as I said, this group has met virtually by Zoom meetings all day long for over a year now. And it's been an incredible opportunity. And just to go a little bit more into detail. So we started with last March, April, over 3,000 applications, and 707 applications were completed. A group of experts, a panel of about 5 people, reviewed absolutely every single submission that was completed within 48 hours. And the ones that had the most potential from either a technology, infrastructure, science perspective went into a deep dive phase. In that phase, there was a team of 5 people who essentially lived virtually with the company for 7 to 10 days and looked under the hood of their project and looked for things like is this technologically feasible? Is there timeline to produce tests, get them on the market within 6 months possible? Who were the right people that the test was designed for? They would come to a steering panel, and we would judge the tests and pick the best of the best. Those tests, 45 of them, made it into what we called Work Package 1, where they got government funding and a lot of support for 4 to 8 weeks. And if they were successful, and usually in that they had to prove that their test actually worked and worked well. One of our academic institutions actually did all the verification of the performance of these tests. They then went into Work Package 2, which is my team, the commercialization support. And we supported everything from helping them get through the regulatory hurdles to connecting them with manufacturers, quality systems, sometimes providing CEOs to slip into the company until they were able to hire. And so subsequently, 33 different companies are in the active phase of producing tests. And we have every test that you could imagine, from molecular to antigen, central lab, point of care, over the counter, home tests, pooling tests. We have gotten all of these tests done. What typically takes about 4 years, we have been able to condense to less than 1 year. This project has been so successful that the NIH now wants to use this as their kind of normal infrastructure for selecting projects that the NIH supports. And some of these tests, if you're into the testing sphere, you may have heard of some of these tests. One of the tests, VISB, for example, is a handheld PCR test that is currently being used by the NBA. Fluidigm on the lower left is all those little ports, allows you to do all sorts of different chemical reactions, and that is currently really useful in variant analysis. They use genomic sequencing. The next test over is called Luminostix. It's a handheld device that clips onto your phone. That's why it's called Clip COVID, and helps read a LFA test. Flambeau on the right-hand side is a complex, high complexity test in a van. And that van is traveling out in the West from rural community to rural community. So lots of different solutions. And that was one of our charges, is COVID is not a one-size-fits-all test need. As you know, we've seen many testing sites with people driving through 2-hour lines under a tent. And our goal was to bring testing to the point of need. And we've had lots of success, and I have seen some really cool tests along the way. However, one of my charges was deployment, getting the tests out into the world. And we realized pretty early on that if we build it, they might not come. It's one thing to manufacture tests, but for all of us who have been in this world long enough, we know that when you need a test, you do one of two things. You either go to a lab like Quest Diagnostics and get your blood drawn, or you go to your doctor's office. We never grew up in a world where you would go to a school to get tested, or a tent to get tested, or think that you might have testing done in Eastman Activity Center. So if we want to bring testing out into the world, there's lots and lots of hurdles that had to be overcome to be able to bring testing outside of healthcare, but actually into non-traditional environments. So one of the core things that we did early on was we did a lot of market research. We talked to manufacturers, businesses, big, small, rich, poor, schools, universities, daycares, assisted living facilities, all of these places that essentially had been either shut down or working at reduced capacity, or terrified that if there got a COVID outbreak, it would really be disastrous. And we learned a lot from them about what were their needs. If they were going to start doing testing, what did they need to be successful? And we learned a lot. I suspect some of this is not that surprising. So first of all, for anybody who had a test, particularly in the first 6 months, you get a test and you get the results back in 3 days. Well, that was pretty useless because if you are running a school and you find out 3 days later that Johnny had a positive test. Johnny's been exposed to a lot of other kids, and what good is that? Cost, these tent testing centers were covered by the government, but if you ran a business and wanted to set up testing yourself, you had to pick up the price. Logistical and operation challenges, as I highlighted, none of these places had ever done testing before, didn't have the right licenses, didn't know how to even get the tests, didn't know how to deploy the tests. There's lots of different components. And then another interesting piece of this is, if you're a company and you decide to do testing, can you enforce it? What if somebody says they don't want to be tested? And that's your whole premise. You want everybody tested to make sure your environment is safe. Additional barriers was, okay, let's say I want to do testing. I have no idea how often I should do testing, what test I should pick, who should be tested, how do I even think about it? As we remember, our prior administration did not put a lot of emphasis on testing, and the CDC has had very, very few guidelines about testing in environments such as work, schools. And if there's no guidelines, what is your liability if you decide to do testing? And then finally, if you are a school or a business and you decide to do testing, are you supposed to report the results? You're not a doctor's office. How does that all work? So lots and lots of issues to help organizations with if they want to do testing, in addition to we need to get them the tests. So a core piece of our focus, in addition to building the tests, was around education, helping groups decide when to test and what to test, and then connecting to be able to purchase tests. Core focus of ours was on education in schools and businesses, implementation guides, how to test, how to bring in testing into your organization in addition to everything else you do. We created a website with a calculator on helping people know what tests to do and how often they should do it. And then last, what we're very happy with, which is we've just launched, is the ability for non-healthcare people to actually purchase tests on a much smaller scale. Now I'm going to pause. Some of you, this is going to be very familiar, and others, it's going to cause a little bit of a brain cramp, and pardon me for going into the science a little bit, but I'm sure you have all heard of antigen tests, molecular tests. You might now have heard of pooling. I'd like to explain a little bit about why these tests are different and what you need to know about them. An antigen test sometimes is known as a home test, a rapid test, an LFA, lateral flow test. That test detects virus proteins. Usually it's done with a nasal swab, and the test results can come back anywhere from like 3 minutes to half an hour. And because of that, it's great. People have been talking about the need of these tests, which has taken the longest to get out into the market, the rapid home tests. Think pregnancy test, a home pregnancy test. This is what everybody's been clamoring for. It's easy to administer and it's not expensive, but it isn't as accurate. And that has nothing to do with the quality of the test. It has to do with the measurement of the protein. And the protein is developed a little bit later in the course of the illness, so we just don't pick up COVID as quickly through an antigen test. And they have the FDA has just approved a couple of home tests, but they are recommending that you test, if you're going to do a home antigen COVID test, you do it twice, one day and then either the next day or the subsequent day. That will increase the accuracy of the test and get you as close as possible to the accuracy of the next, which is called the molecular. The molecular tests, you've heard of a PCR test, an RT-PCR test, you've heard of central lab tests. NGS is genetic sequencing tests. So those detect the genetic material in the nucleus of the virus, and you can get this material by those god-awful deep nasal swabs, anterior swabs, saliva, which people are very happy about. So lots of opportunities to collect the sample. The advantage, as I was hinting at, is it's really accurate. And there are some rapid 30-minute rapid handheld PCR tests. They're very expensive, but they're very good. The disadvantage is if you have to send it to the central lab, a lot of the turnaround time is actually the logistics. It's getting the sample to the central lab. The central lab tends to process it in large batches and then reports back. So now turnaround time can be as short as 24 hours. Still, a lot of places are in the 48 hours. And obviously, if there's a positive test and the person isn't quarantining while they're waiting for the results, you can spread it. And it is also much, much more expensive than an antigen test. So most recently, they've been talking a lot about pooling, particularly in schools. And I'm going to pause here to talk about what's coming in the future. Despite the fact that probably virtually everybody on the phone is vaccinated and we're really excited to get back to life, the country is probably a good 6 months away from herd immunity, and kids will be the last group to be vaccinated. And we want schools to be open, so the government is now spending approximately $12 billion on supporting national testing in all schools, starting hopefully within about 6 weeks and going through December of this year. And one of the ideas is pooling. If you get all the kids in a class and collect their swabs or their saliva and do a test on that combined sample, you can do it so much more inexpensively. If that entire pod or pool or classroom is negative, go on through your day. If that pool is positive, then every kid in that classroom should be tested before going back to class. It is a great in-between solution that is less expensive and works if there's not a high prevalence of the disease. Still has the problem of usually being done in a central lab, so the turnaround is usually 24 to 48 hours. But if you're testing kids, let's say once a week, and their class gets tested regularly, it's felt that it's okay, keep the class going, get the result. If a pool is positive, the kids will go home until it's all cleared up. If one kid in the pool is positive and they've been in contact with the other kids, you do virtual learning for about a week or so, and then you go back to normal. So we expect a lot more testing to come in the next 6 months, even though many of us hopefully are past the difficult phase. So I just highlighted briefly, antigen tests are good for screening. They're most accurate if you're already symptomatic, but perfectly fine for things like day camps, manufacturers, dentist's office. Molecular tests, we should use it when certainty is vital, particularly in medical care or high value employees. You can decide on your own whether the NBA deserves to be considered a high value employee and use the very expensive handheld PCR, point of care in an emergency room. We're thrilled right now. One of our tests is being used by the government in a project to bring point of care to emergency rooms, because in the last couple of 6 weeks or so, we learned that if you find somebody positive and get them intravenous Regeneron treated with biologic agent within 48 hours of diagnosis, they're a high-risk individual's chance of being hospitalized drops to 4%. This has been a treatment that we've been waiting for a long time. This is exactly what the president received within 48 hours of his diagnosis. And so having the ability in an emergency room to diagnose within 30 minutes of somebody who is symptomatic and get them Regeneron or something similar very quickly is a wonderful, wonderful tool. And then last but not least is pooling, as I mentioned. And now I'm just going to give you some highlights of some of the content on our website, whentotest.org. We have lots of information about how to think about and how to actually hold your hand to implement testing. We have a playbook that the CDC and the NIH is thrilled with about how to implement testing within schools, and it's coordinated with not only testing, but how to do social distancing and think about ventilation and washing hands and isolating and contact tracing. If you've paid much attention to the COVID epidemic, and I know you've learned a lot through these virtual classes, the media really tends to hit many of these topics kind of as one-offs, like everybody should wear masks and everybody should social distance. But putting it all together about how wearing masks and social distancing in a ventilated space with contact tracing and testing, how do all of the pieces work together? And that's been a huge focus of our organizations, is trying to pull all the pieces together. So for example, in the school process or education program we tried to make the analogy between fires. You know, we think about preventing a fire in our house. We are careful about our appliances. We have smoke detectors. We have sprinklers. We put all of the pieces together. And that's the same way with COVID. It's not just wearing masks and social distancing. Is if there's a positive case, you want to do contact tracing, you want to quarantine people, and you need to add COVID testing in the mix of it so that you can isolate and determine early on who is positive so that you can pull them out of the risk area. So now I'm going to highlight something we're very proud of, which is a website, whentotest.org, available to anybody. And it really is geared for schools and businesses and manufacturers. This, if you go to the website, the site is highlights all of the different places that we are focused on. The calculator has been developed by some experts from MIT and MGH. And I am not going to the live site, but we'll show you some snippets of how the calculator works. The concept is, if you know whether people are wearing masks and what types of masks, and if they're social distancing or if they're having lunch together, if you know the prevalence of the COVID in your community, and you know your tests and how accurate they are, what's their sensitivity and specificity, you can actually mathematically determine how often you need to test in your environment to prevent an outbreak. You can't prevent any individual case, but you can prevent the spread in your environment. So you can't see this very well, but essentially if you go to the website, this is the website, and what you will see is it'll ask you how many people are in your organization. So let's say you have a summer camp at Eastman and you have 60 kids planning to go to summer camp. You would put in 60. And you say, okay, how many are going to reliably wear masks? Well, you know, you want to say 100%, but nobody ever wears masks 100%. We all see those folks with the masks slipping below their nose, or they take it off to talk, or they take it off to eat. Whether you have a contact tracing program, or whether everybody's having lunch together. And just last week, I don't have a screenshot of it, we asked what percentage of your participants are vaccinated. And then there's cost considerations of whether or not you're paying for people to actually do the testing. And what comes out is based on different types of tests about how much this program would cost you. And this was based on 1,000. So we don't want you to freak out that that's how much it would cost to run a testing program for Eastman Camp. But how much it would cost you, and sending it off to a central lab would cost a whole bunch, but using an antigen LFA test would not cost nearly as much. But on the below tab, you see that if you're using a less specific and sensitive test, you have to test more often than if you are sending it off to the lab. And there's all sorts of different features on the website, giving you lots more specific information about each of the different tests and whether or not, if you happen to be in a hotspot condition, meaning your prevalence of the infection is much higher, as well as you, as I mentioned, you can put in cost considerations, and you can put in, actually put in very specific details about the tests that you're using.
Nancy, can I interrupt for a minute?
Please, please.
Or Paul, do you want to do it?
Yeah, Richard Sachs has a question.
Oh, go right
He has
ahead.
to put it in the Q&A though. So just a reminder.
Perhaps you could continue, and once I see that it's in the Q&A.
Okay.
Right, just a reminder that the chat, you can't put your hand up here for this type of a webinar. So please use the Q&A.
Great. Well,
Sorry
we're getting
for the
pretty,
interruption.
no problem, and we're getting pretty close to the end. The last piece that I wanted to share with you is one of the challenges for the average organization or individual is, unless you're a healthcare center, it's really hard to get tests. You could go to a facility to get tested, but if you want to buy tests, where in the world do you go? We've partnered with a group called Project N95. This is a non-for-profit organization that started around last summer. They realized there's a similar problem that people wanting to get PPE, personal protective equipment, such as masks and gowns, had no easy way to do it unless you were a big, large healthcare organization. And they created an infrastructure for a marketplace, and we have partnered with them so that we will now be able to have tests available for purchase on this marketplace. You can see in the upper right-hand corner our diagnostic kit logo, and we have 2 test groups up already. In the next 3 to 4 weeks, we expect to have many more, and that is projectn95.com is the website. We will be providing a link to that website. Paul, do you have the question?
Yes, I do. Ken Dolkart is asking, the recent 1.9 trillion COVID relief bill provides some temporary funding to schools for testing. As higher risk groups achieve immunity, do you envision state health departments assuming such testing? And how might such immunity change the role of the point of care and industry testing?
Great, thanks, Ken. So a couple of things. The money is absolutely earmarked for the school testing. The HHS is running the program. The country is going to be divided into 4 hubs: Northeast, South, Southwest, and West. And those hubs, there will be one organization in each hub running the testing program. For the first 6 months, the tests and the funding for all the tests will be provided by this government program. The hub that is awarded the contract is going to work with the states all the way down to the county levels and have an entire infrastructure for the coordination and execution of the tests. There's been lots of conversations about how vaccination is going to impact it, and I think that's one of the reasons why it's currently funded until December. The expectation is that the students will be following on with tests, with vaccination a little bit later. As you just probably heard, 12 and above look good from a research perspective. Looks like the vaccine works well, 100% effective in the trial, but that still doesn't get us to elementary schools. In addition, they're also saying that about 40% of people so far are still saying they don't want to be vaccinated. So we're not going to hit herd immunity for a while. We're going to continue to have outbreaks here and there. And so testing definitely needs to be part of the plan for the next, at least until the end of 2021. It's actually causing a lot of distress in the CDC right now, that we're starting to enter another little bit of a spike. And I think we are all expecting, unfortunately, as people get more and more confident with the vaccinations, we're going to continue to have many outbreaks throughout the country probably this year. And therefore the need for testing is not going to go away. And the need for right now, the demand is lower than the capacity because people have kind of been done with it, but we think it's going to continue to have periodic spikes as outbreaks continue to happen. I hope I answered the question, Ken.
I have actually figured out how I can unmute Richard Sachs. So, Richard, if you can unmute yourself.
Richard seems to still be muted.
Right. No, I'm asking to unmute, but it's not working. Okay. Okay, Q&A.
Is there another question? You want me to walk through an example, this scenario? I only have 2 more slides left.
No, we're good. Ken, thanks you for your answer.
Okay, good. Excellent. Thank you. Thanks for the question, Ken. So I thought it might be helpful just to give you 2 concrete scenarios of how you might think about, or an organization might think about setting up testing. Here, this is a real life example. We had a manufacturing plant with 150 employees. 50 of them were in office and the rest were on the plant floor. They, in theory, had lunch 6 feet apart in the cafeteria as they were supposed to. The plant was doing great. the CEO was terrified of closing down because they had more business than they could keep up with. And then all of a sudden, 3 cases in the plant reported positive, and lots of people started calling in sick. Given that it was an acute situation, they needed a fast turnaround. They wanted something at point of care. They were really concerned about, you can't just send off results and get them 3-4 days later. Cost was important, but closing the plant down was more important. They were able to get their hands on a point of care PCR test, and they tested absolutely everybody. They had 11 positive tests out of 100 people on the floor. They all went, those 100 and their immediate contacts went into quarantine. In order to do that, they had to get a CLIA waiver, they had to get a prescribing physician, they had to get PPE, biohazard, so they really needed some support in the logistics to get going. But within 2 weeks, they were able to get 100% back up and running. They had an ongoing testing program, and they had no further cases. So it was a good news story. And here's a scenario of a dental office. The dentists say, you know, I'm not seeing as many patients as I can because we have to limit the number of people at any one time. If I could test my staff and my patients every single day, we could just see lots more patients and reduce everybody's anxiety. Not so worried about if the test isn't perfect. If he's going to test his staff every single day, he would be able to catch any false negatives. And if a patient turned out positive, they could go home and get a repeat, more precise test. And so the solution for the dentist office is obviously do a antigen, one of the rapid low-cost tests, and keep his office open as effectively as possible and be able to cover the cost and not obviously have to lay anybody off during the interim. So with that, let's go back and see if there's any other questions.
No, let's see, no questions at this point. I just want to say I'm very impressed with your description of how this project was put together. It frankly, it sounds like a Manhattan project.
Yep. And you know, we had a phenomenal team, really dedicated people. One of the things that I can share with the group now that we have a new administration, up until November, we were everybody was working hard, but we were working hard under the radar screen. And starting in December, all of a sudden, everybody from HHS and the CDC and CMS, we started meeting with all of the different government agencies, and it was like this incredible weight was lifted off of everybody's shoulders so that we were able to do more even faster and get the word out of all of the different pieces. For example, the CDC became very excited about all of our community research and all of the tools. And before November, we weren't meeting with the CDC. So it's just been great to see how effectively the government agencies are now really working together to really handle COVID. And for example, I was asked to be on the review committee for the HHS school-based program. So the different government agencies are really trying to leverage all the expertise that's out there.
So we have another question. Philip Weber is asking, when will individuals be able to pick up tests from their local pharmacy and self-test at home?
Very, very soon. So Phil, in a matter of a couple of weeks, I would first recommend you go to Project N95. I think you'll be able to get home-based tests there within just a couple of weeks. I'm keeping my fingers crossed that you could buy it online and have it delivered to home. I think that the pharmacies are now in the process of negotiating. Quanterix just had their home use EUA approved for a rapid test, and I suspect we'll be seeing those within pharmacies within the next 6 weeks as well.
Well, I'd just like to comment that both Paul and I have worked for the government, and this is an incredible example of cooperation between agencies. And, you know, it's not something that you see all that often. And so I am just extremely impressed by how well this has all worked. And this talk has been wonderful, really, really wonderful. Paul, do you have other questions at this point?
None in the Q&A. Do we have time?
Yes, yep.
Okay, so maybe you commented on this, Nancy, but this whole process, do you think that this is going to, or how is this going to change our systems in terms of considering or producing new tests as we move forward?
So there's a whole variety of very positive outcomes. Number one, from a government perspective, the NIH is completely convinced that their old process of receiving applications, giving people a bunch of money, like $1 million or so, and then coming back a year later and saying, "So how'd you do?" is pretty much out the window. They learned that this type of rapid evaluation acceleration can produce dramatic results very quickly. And as you can see on our funnel, we got rid of projects. Good people trying to do good work, but the test didn't work. So after 8 weeks, government funding stopped and they were told, go back to your lab. So I think from an NIH perspective, they are going to use this type of a model going forward significantly. The other piece is part of our process in selecting the tests. We gave preference to tests that were going to be amenable for future needs. So whether it's the next pandemic or whether it's another type of test condition, like, I don't know, toenail fungus, the tests that we selected, many of them could easily be adopted for a different type of infection. Two things have happened with the pandemic. Number one, the world of telehealth has exploded. So virtually everybody's had a telehealth visit. This whole model has brought testing out of the physician's office and is trying to bring it directly to the public. So I would anticipate in the future a much more home diagnostic tests to blend with telehealth, making that transition of care from going into a doctor's office to actually to a home where a diagnostic test could be performed at the home with a telehealth visit, and definitely reducing the numbers of trips back and forth. And so many of the tests that are through our system will easily be modified to test other conditions. And along that, just to let you know, one of the teams we have working now is variant analysis. So all of our tests are being analyzed to make sure that they pick up the variants. And we were very happy that we had selected tests that could easily be adjusted for different, to pick up different types of proteins or RNAs so that they are virtually all amenable to be adjusted for the variants. So, so that long-term vision was definitely in our minds.
And if I may extend my privilege, are there, what rules are there for assuring that the public health system learns of the test results, the variants, the discovery of a new variant, et cetera?
Right. So the discovery of, so I do have to say we learned in the last 2 months that there are a lot more variants in the US than anybody ever thought. The CDC was woefully underfunded to do surveillance testing, and that has changed dramatically. And we have actually been working hand in glove with the CDC to share what we're learning. So there's a lot of variants. So I think this was a really important lesson learned, that the CDC has to maintain the infrastructure to be able to do the surveillance themselves, which they were not. From a reporting perspective, that is another example of, unfortunately, a huge challenge for the government, and clearly it became obvious that the entire public health infrastructure was woefully underfunded and woefully under-supported from an IT perspective. And Paul, I'm sure you know this well, that every single county and every single state has a different infrastructure, and none of the IT infrastructures talk to each other, so that there is no single reporting infrastructure. So none of the tests could easily report back to an EHR, a doctor's office, HHS, and their local state department. The infrastructure didn't exist. The government is currently building that infrastructure. They are building a single reporting infrastructure, but it's not going to happen robustly enough in the next couple of months to make it easy to do reporting. However, all of the manufacturers are aware that no matter who they sell the tests for, they have to make it clear that reporting the results to their local state health department is a requirement of doing any of this testing.
I have no other questions in the Q&A.
Okay.
There's nothing new in the chat.
Okay, then I'll take this opportunity to thank Nancy, Dr. Gagliano, for all of her work on this. It's really very impressive, and it was an excellent talk. We really appreciate you taking the time to share it with us.
Thank you, my pleasure.
I invite everybody to come and hear Dr. Ken Dolkart. April 30th would be our next talk. And again, if you have any feedback for us, evaluation, suggestions, whatever, Eastman cares at eastmannh.org. So thank you all for joining us, and we'll see you next time. Thank you again, Nancy. It's really appreciated.